Dr. Tăng Hờ Chiếm, Dr. Ngô Văn Hùng, Dr. Dương Minh Án, Dr. Lưu Hồng Ban, Dr. Rajinikanth. Yeah. Yeah. And our topic is the imaging and physiology guided the BCI. I think nowadays, interventionist, when we do the BCI, we often aim to the optimal result, and we need the very important role of the imaging and physiology. So the first topic, we would like to invite Professor Tăng Ho Chim with the topic multivessel BCI. Is physiology needed or is angiography enough? Please, Professor.
Good morning. Thank you very much for the introduction. It's a real pleasure to be back in the SIF meeting, and I'm going to be covering the topic of multivessel. PCI is physiology always necessary. I've got nothing to disclose for this particular presentation. When we talk about patients with multivessel PCI, we always refer to the term of complete revascularization. And the definitions of complete revascularizations are sometimes not familiar to many people. Are we talking about anatomical complete revascularization, or are we talking about ischemic complete revascularization? And sometimes there's also this concept of reasonable incomplete revascularization, where you only treat what is necessary and not necessarily all lesions that appears to be ischemic. We know from the syntax trial 10-year follow-up that incomplete revascularizations portends a poorer outcome, whether it's for PCI or for CABG, and that can include a mortality difference as well. On the other hand, we also know that physiology also is an independent predictor of lesion-related outcome. When you look at this particular chart here, and when you have an FFR of less than 0.8, you can see that there's an exponential increase in terms of major adverse cardiac event as you follow up these patients. So FFR do have a predictive value as well. So for patients with multivessel coronary artery disease, do we have to take out FFR and do a physiologic test? We can classify that into 4 groups of patients: STEMI and STEMI, patients with cardiogenic shock, and patients with stable coronary artery disease. I think for STEMI, we are pretty well endowed with a number of clinical trials from primary, corporate, and pre-multi. And all these trials shows us that complete revascularizations, whether it's immediate or stage, of all the patients' coronary artery disease actually carries a much better outcomes in terms of the clinical endpoints. What is also very important is that when you look at the culprit trial, specifically looking at hard clinical endpoints of all-cause death and myocardial infarction, complete revascularizations of both the culprit and the non-culprit lesion actually carries a significant difference. So what about using FFR to evaluate the non-culprit lesion, which I'm not sure what everybody do, but there are actually 2 trials here that tells us that the use of FFR as a form of guidance, as a form of strategy to treat the non-culprit lesions can perhaps bring about better benefit. We have the Dynamic 3 pre-multi and we have the Compare Acute. Both of them, however, did not show a reduction in hard clinical endpoints. They only show a reduction in the need for repeat revascularizations. And when you look at Dynamic 3 10-year follow-up, that reduction in revascularizations actually carries all the way to 10 years. So it is actually safe to not intervene in the non-culprit lesion that is deemed to be non-hemodynamically significant when you adopt this particular strategy. What is important to me as far as this trial goes is that, unfortunately, in our patients with STEMI at 10 years of follow-up, nearly 50% of patients will still develop some kind of event following whatever treatment that we have for secondary prevention. There are actually 2 other trials that support a physiology guided besides the Dynamic 3 and the Compare Acute, and this is the FIRE trial and the FRAME AMI, both of which are ACS trial. Not all of them are STEMI, but a significant a number of them are. But there is a significant reduction in terms of a composite ischemic endpoints. While you have a positive FF trial, you also have a negative FF trials telling us that a physiology guided may not necessarily be necessary. So we have the FLOWER AMI trial, which tells us that the guided strategy from based on FFR did not reduce composite risk at 1 year. We have a full reverse trial again telling us that FFR is not needed. So in this cases, angiography, just a visual estimate of the non-culprit lesion, is good enough. So when you have all this positive, negative trial, what do? You do a meta-analysis. And this 2022 meta-analysis, combining all this physiology versus angiography guided trials, give us two important messages. Number one is that complete revascularization is always better than incomplete revascularization. Number two message is that FFR-guided complete revascularization is not superior to angiography-guided complete revascularization. So what's happening here? Perhaps we are looking at two different things here. Physiology looks at the flow severity and the subsequent need for ischemia-driven revascularization, which is what we see in the pre-multi-dynamic trial. But angiographic selection actually tells the operator which type of lesions are more complex and perhaps more dangerous and more vulnerable to a future event. So perhaps we need a larger trial called the Complete 2 trial, where now you have 5,000 patients STEMI randomized to both angiography and physiology to finally answer these questions. The second group of patients that we look at is the NSTEMI group of patients. When you look at NSTEMI, actually way back 10 years ago, we already had this trial called by the British Heart Foundation called the famous NSTEMI trial, where you look at NSTEMI patients and then you do a FFR and you defer those who have a FFR of more than 0.8. And it turns out that it is actually quite good. So by using this FFR strategy, you reduce the need for revascularization, which is something that we all agree. And there was no price to pay. There was no difference in terms of major adverse cardiac event. In a later trial called the BioVasc trial, where you do a complete revascularization of patients with NSTEMI at the time of the PCI, you find that immediate complete revascularizations is actually okay for patients with NSTEMI, but this were all angiographic based. This were not FFR guided. So now, what about cardiogenic shock patients? Well, we have this very important trial called the culprit shock trial. It tells us that you only need to treat the culprit lesions and you don't have to treat all the other non-culprit lesions at the time of therapy. Now, this has actually benefits in terms of the 30-day total mortality and the need for a renal replacement therapy. But I just want to caution here is that culprit shock was done in an era where there was no hemodynamic support. Perhaps that would make a difference in the patients with multivessel disease. And finally, in the stable CAD, as we approach somebody with multivessel coronary artery disease, do we always need to take a physiology approach? FAME trial is a very important study to address this particular issue. And we know from the FAME trial, up to 1 year, which is the primary endpoint, there was a significant reduction in an event-free event occurring in the FFR-guided group of therapy. What is also more important in the FAME2 trial is that you have a positive FFR, it is actually beneficial to do PCI compared to just medical therapy. So for stable CAD, I think some of us will still want to do a physiology if you are in doubt. But when you look at future trial, which compare angiography versus FFR guided in multivessel CAD, it turns out that actually there's no difference. Again, a visual estimate by angiography is good enough for stable CAD in contrast to the FAME trial. What is even more striking in the future trial is that a FFR-guided strategy actually result in a higher all-cause mortality in the patients who has got a higher complexity in terms of syntax score more than 32. So maybe sometimes a visual estimate as a control may be good enough. So if FFR is not good enough, angiography perhaps not perfect, what about FFR versus IVUS? Take an IVUS catheter down and look at your lesions and see whether it is good for indication. So IVUS, we have a criteria of MLA of less than 3.2 in this particular study by in Flavor from Korea, and it tells us, again, very important information. That if you use a FFR guided, you run the risk of a higher incidence of target vessel revascularization in future. But if you go by an IVUS guided, then perhaps you may reduce the incidence of a spontaneous myocardial infarction in future. So that is the price that you trade off in patients adopting this approach. So when you have things like that, let's look at the guidelines. Actually, I always find the European Society of Cardiology guidelines as being more enlightened. 2024 recommendations is that you will use FFR or QFR for guidance in terms of intervention in patients with multivessel disease. But in the American guidelines, whether it's ACS or whether it was CCS, it was silent as far as the recommendations for physiology-guided intervention. So in conclusions, I think complete anatomical revascularizations do improve clinical outcomes in the long term. An FFR-based strategy do reduce the rate of revascularizations, particularly at the time of intervention. But the treatment decisions based on FFR have not conclusively shown any improvement in clinical outcomes of patients compared to angiography-guided strategy, which is still the standard of care, whether it is for ACS patients or for stable CAD patients. What it means is that we probably need a more randomized trial, bigger sample size like it can complete to address the role of physiologic assessment in patients with multivessel coronary arthritis. Thank you very much for your attention.
Thank you, Dr. Tan. Nice lectures, and so emphasize the importance of physiology guide PCI and also the complete revascularization. Are there any questions or comments from the panelists?
Good morning. Thank you very much. Thank you very much, Prof. Always enjoy your talk. We agree the evidence is very strong for complete revascularization, especially the STEMI setting. In the practical world, does it mean that we have to complete revascularize at the time of doing the primary PCI? Or are we talking about we're able to stage that procedure but complete it within a certain time frame?
I think, first of all, whether you need to completely revascularize all anatomically significant lesions or not is questionable. There are lesions that probably subtends very limited myocardium or something that's not worthwhile intervention. So I will go for an approach of reasonable, incomplete revascularization approach. I will revascularize what I think are clinically and prognostically relevant. Now, whether you want to do it at the point of the procedure and whether you want to stage it, I think it depends on the clinical context again. So I think if the patient is someone who come in STEMI, I'll do it at the stage procedure. But somebody end STEMI, very stable, I'll just go ahead and fix whatever I think is necessary. So I think it has to be contextualized in the patients. Yeah.
Morning, Prof. Thanks. Great talk. Can I ask you a question? Is there a way to combine imaging and physiology in assessing non-culprit lesions following STEMI, especially OCT? You mentioned IVUS, but OCT could show up more. Is there a way to come in sort of practical terms?
Practically, it will be a costly approach to do both imaging and physiology approach. Well, what the evidence does suggest that actually angiography is good enough.
Okay, so thank you, Dr. Tan, again.